Okay, so welcome back to part 2 of this lecture, New Perspectives from the Integrated Systems Model. And the topic now is going to be on a lecture that's been called Split Down the Middle, Diastasis, Rectus, Abdominis, and the Implications for Form and Function of the Trunk After Pregnancy. Now, pregnancy isn't the only way that you can split your middle, and it's not a condition that is unique to women, although more women than men. I've seen more women than men with this condition. Men can also have this condition, but it is usually related to excessive fat in the omentum, which creates increased intra-abdominal pressure that ultimately stretches the Linea Alba. And the other cause that I've seen for it in men has been in a fellow who actually did 200 sit-ups every morning for 40 years using an internal oblique dominant strategy. And he actually just literally pulled his Linea Alba apart over time. But this lecture really is going to focus on postpartum women because that was the subject group of the trials that we've been doing. Okay, so it all started a long time ago now in 2006 when I started to see more and more women presenting with these wrinkly, bulgy bellies and that appeared to have absolutely no structure between the left and right rectus abdominis on ultrasound imaging, as you see here on the ultrasound in the bottom right. And I started to see more and more of these because in Vancouver, women who fail to get better after pregnancy are often referred to our clinic for consultation. And what I wanted to know is what was the impact of the diastasis on trunk control, and what was the role of this little bit of tissue, the Linea Alba, connecting the left and right rectus abdominis to trunk control. And so I happened to be speaking at a conference where Paul Hodges was also presenting and had the opportunity to show him some of these ultrasound images and some of the clinical video clips I had on my computer. And I said to him, Paul, what's going on and what is the role of the fascia? And his response was, well, we don't know. Nobody's actually done some studies looking at it, so why don't we? So he suggested that I apply for a research grant from the Clinical Center of Research Excellence, which I did. And in 2008, I was awarded a grant to investigate or to look at both healthy and subjects with the DRA, and to look at the behavior of the Linea Alba to see if we could get some more information around what the role of this tissue was in trunk function. So how common is this diastasis rectus abdominis anyway? It was very difficult to discern from the literature. There's very few studies. Gilliard and Brown in 1996 state that 100% of women have a DRA in their third trimester, and this number is bigger than the Boiseneau and Blazchuk study in 1988, and this certainly concurs with my clinical experience in that it's impossible to stretch your abdominal wall as far as it needs to go in the third trimester without having some widening of the Linea Alba. So it's unanimous. 100% of us have a DRA in your third trimester. And many of them remain abnormally widened at 8 weeks postpartum. And Yvonne Coldren from the UK has measured this distance over a period of a year. And what she found is that without intervention, what you have at 8 weeks remains unchanged at 1 year. And a follow-up study of Leal certainly confirmed the same findings. And that while they found that the distance certainly changed from 8 weeks to 6 months, they would concur that in many, the distance is still larger than so-called normal at 1 year. Now, it's not just the Linea Alba that stretches. Yvonne Coldren also showed that the rectus abdominis muscle itself stretches, and that was the same finding as Brauman. So it's not just the Linea Alba. And as I mentioned earlier, Teresa Spitznagel from Chicago showed that 66% of women with the DRA have a pelvic floor support dysfunction. And at the moment, this is about all we really know about the prevalence and how common the DRA is. Now, how all this began for me was, again, with a patient in the clinic that usually tends to drive my curiosity. And this is Christy. And she was a 32-year-old mom at the time who had had 2 babies, 19 months apart, and both were delivered by C-section. Now, C-section doesn't cause a DRA. It just happened to be her method of delivery. Her meaningful complaint was pelvic girdle pain, 4 on a 10 on a visual analog scale, and her pain was aggravated by those things that typically aggravates pelvic girdle pain, and that's vertical loading tasks, and also rolling over while supine lying. The only way she'd get relief was by constantly changing positions, because when your pelvis is aggravated, there's very few positions which actually afford relief. She had no reported complaints of her continence mechanism, and she'd done lots of core exercises with no benefit, in that she hadn't been able to reduce her pain or improve her level of function. Now, in the one-legged standing test, vertical loading task, what we can see is that she had unlocking of her right SI joint. She also had a positive left active straight leg raise task, and these are the 2 tests that we took into the study. And the interesting thing was that pelvic girdle compression did not reduce the effort required for her to lift her leg. In other words, her pelvis was not the primary driver. What reduced the effort for Christy to lift her leg was when the left and right rectus abdominis were approximated together, suggesting that the abdominal wall impairment was in fact driving her failure to transfer load through her pelvis in this task. Now, the curl-up task is a task which involves all of the abdominals, and it's the one that we chose to use in this study. And you shouldn't be able to sink your fingers through the abdominal wall when somebody is co-activating the abdominals like that. So we looked at on ultrasound, and the interesting thing was that there didn't appear to be any linea alba. We couldn't see any structure between the left and right rectus abdominis. And just above the pubic symphysis, again, it seemed to be just hanging on by a thread. There didn't seem to be much structure there at all. So whenever you have unlocking or giving way of the SI joint, you need to check the form and force closure mechanism. So here I'm checking the mobility of the SI joint, and then asking her to recruit the deep muscle system. And in a healthy situation, with optimal recruitment, all the movement of the SI joint should be gone. And I can still feel movement at this SI joint when Christy attempts to recruit the deep muscle system. So the next question becomes, well, is she able to recruit the deep muscle system well? Because it's extremely difficult to feel tension in the abdominal wall in these women who have a DRA. So number one, is she recruiting the deep abdominal wall? And if she is, well, then that suggests that the force closure mechanism is not intact, in that her abdominal mechanism is not able to force close and thus stabilize the form of that left SI joint. So this is where ultrasound is absolutely essential. And when you image Christy's abdominal wall, you can see that she has a beautiful activation of the deep muscle system. And yet this co-activation of her left and right transversus is unable to increase the fascial tension between the left and right side, and thus force close and control movement of the SI joint. So to confirm that hypothesis, a second therapist comes in and feels the neutral zone of motion of the sacroiliac joint. I hold the edges of rectus abdominis together. Christy then connects to her deep muscle system. So now we've given her transversus a stable base from which to contract. And so there's still movement until she contracts the deep system. When she contracts the deep system, all the movement is gone, which is a normal response. I let the abdominal wall go. Christy connects again, and the movement is still there. So this suggests that if a surgeon was to do this, if a surgeon was to fix her abdominal wall and close the diastasis, that we would be able to train Christy's strategies in such a way that she would be able to transfer load successfully through her pelvis, and theoretically her pain should decrease. So in spite of our best efforts to restore optimal function for Christy, she was unable to control movement, and we felt that she would benefit from surgery to repair the abdominal wall. And so this led to a number of questions around women with diastasis rectus abdominis. The first one being, well, how wide can the linea alba be before a surgical repair should be considered? Is there a magic number that when we measure this on the ultrasound, we can triage people directly to surgery as opposed to putting them through training first? What was the best way to close the diastasis? Note these words are in green because this is what we thought was important at the time. What's the best way to close the gap and restore the force closure mechanism? Could we identify specific key findings from the assessment that would help us determine who we should triage to surgery and who could we train to restore optimal strategies for function and performance? So these are the questions that drove the research initially. Now, when we look at the deep abdominal wall, we know that when transversus contracts, it draws laterally, it broadens, and this drawing lateral movement increases tension in the fascia, and this is what's felt under your thumb. So when there's an optimal contraction, isolated responsive transversus, what you should feel under your thumbs is an increase in tension in the aponeurosis of the transversus abdominis. And Schneiders and Vleming have proposed that this fascial tightening between the left and right ASIs is what in part provides the force closure mechanism for the sacroiliac joint. And all of this will depend on the integrity of this small bit of tissue between the left and right rectus abdominis, namely the linea alba. So if we look more closely at the anatomy of the linea alba, this is two pictures that have been redrawn from Gray's Anatomy. And I think most of you will be quite familiar with these illustrations. We've been taught that the aponeurosis of the abdominal muscles have a very specific architecture, and that above the umbilicus, or above the inferior arcuate line actually, the aponeurosis of the internal oblique splits around the anterior and posterior part of the rectus abdominis, and that the aponeurosis of the internal oblique then crosses the midline to merge with the aponeurosis of transversus on the opposite side. And so this structure, or this mechanism, or whatever you want to call it, would actually end up functioning very much like Scarlett O'Hara's corset, in that when you tighten the laces of the corset, it would draw the left and right sides together. And this is the foundational premise of the Tupler technique, of Julie Tupler's technique for her protocol for diastasis. And it would be a valid premise or hypothesis if the anatomy was accurate. But unfortunately, the anatomy is not like this at all. In fact, the abdominal muscles cannot close the diastasis. They may be able to prevent it from opening, but they cannot close it. So the whole premise around the Tupler technique is inaccurate. Because this is what it looks like. This is just a redrawing of a picture from an Axer et al. Study, in which they used confocal laser microscopy to image the orientation of the collagen fibers in the linea alba. And it's highly organized structure, in that the ventral 2/3 of the linea alba is formed from collagen fibers that come from the ventral rectus sheaths. And these fibers are actually derived from the aponeurosis of the external and internal oblique. Now we're talking about the aponeurosis above the inferior arcuate line. So this is just below the umbilicus, and then above the umbilicus. This is what it looks like. Now the posterior 1 to 2/3 is formed by these very longitudinally oriented collagen bundles that come from the posterior rectus sheaths, and they are derived from the aponeurosis of transversus abdominis. So interesting, okay? Not too sure what all that means, but it's a very organized structure. Now, Grazel and his team sort of did some compliance studies, stiffness studies in the linea alba, and was able to show that the linea alba is the stiffest longitudinally, and the stiffest transversely, and it has the greatest compliance, which means it's the most lax in a craniocaudal plane. So it allows the abdominal wall and the linea alba to lengthen from pubis to xiphoid, but it resists left to right strain. Below the umbilicus, the compliance is smaller in the transverse direction compared to an oblique direction, and this is in normal, healthy individuals. Well, how wide can the linea alba be normally anyway? And the width of the linea alba is also known as the IRD, or the Inter-Recti distance. And there's been a few studies that have measured this, and the one study which is gender and age matched to our study is the one of Beer in 2009. And They used ultrasound imaging to measure the width in 150 nulliparous women. And they found the width to be quite variable at all three levels, at the xiphoid, 3 centimeters above the umbilicus and 2 centimeters below the umbilicus, and that the shape of the linea alba is much more like an ovoid. So maximum width at the xiphoid would be 1 to 1.2 centimeters, just above the umbilicus, 2 to 2.2, so about 2 fingers width, just above the umbilicus, and 2 centimeters below the umbilicus, but still above the inferior arcuate line, 1 to 1.4 centimeters. Okay, so that gives you a bit of an idea as to what the means are. But we found in our study, when we looked at it, we found people that were wider than this, and we found people that were narrower than this. And that's the problem with average numbers, isn't it? Now, Mendesenau and Mota, and this is a study Carrie Bow was involved in as well, showed that ultrasound imaging is an accurate method for measuring the IRD at and above the umbilicus, but not below. And we had a lot of difficulty getting intertester reliability below the umbilicus as well, because the left and right rectus abdominis, we call them these kissing heads of rectus abdominis. So below the inferior arcuate line, they really don't have there really isn't a linea alba. There's just an approximation of there. It's a very, very small or short linea alba. So this gets us to our studies now. So what we did is we looked at the behavior and the morphology. So the shape of the linea alba in 17 healthy subjects and in 26 women with DRA. These were the subjects that were included in this study anyway. And the first thing we did was to measure the inter-recti distance in 3 different tasks. We looked at it at rest. We looked at it during an auto curl-up task, so just a short head and neck curl-up. And also in a curl-up where they pre-contracted the deep system. So the subjects were given a cue to connect to their pelvic floor. And regardless of what that did for them, they were included in the study whether they had an optimal or a non-optimal strategy. We were just interested in looking at did the connect cue yield a different behavior of the linea alba when they did a curl-up. And then we measured the inter-recti distance between the left and right rectus abdominis as a chord, namely the shortest distance from left to right side in all 3 tasks. And you see on the figures here at rest, during an auto curl-up, and during a connecting curl. And our measures were subjected to both intra and intertester reliability, and it confirmed that we were reliable. Now, the next thing that we did for both groups is that we determined something that Paul Hodges has called a distortion index for the linea alba. And on the drawing on the bottom here, this wrinkly line at the top here would be a tracing of the linea alba in somebody who had a DRA, and for example, this would be during a curl-up task. And the line at the bottom would be the chord, or the so-called shortest distance from left to right side. The green fill in the space there represents the area of that shape. So the area of that shape was then divided by the chord, the length of the chord, so that we got an average distance of any point of the wrinkly linea alba from the straight line. And this gave us a number for each of the tasks and each of the subjects, and that number was called a distortion index. So hopefully that makes sense. That was Paul figuring that out, not me. So we also rated the quality of the abdominal activation from the lateral abdominal wall using ultrasound imaging during both of the strategies. And what we'll do at a later date is look at the relationship between the strategy and the behavior of the linea alba. We'll see if there's a correlation between the two. And so these were ranked according to 3 different classifications. They either could do it well, an optimal co-activation, which is what should happen. They had intermittent or inconsistent activation of transversus, or no co-activation, so it was all IO dominant. So those are the 3 classifications that we used. So let's take a look at one of the healthy subjects here. And what we were looking for in a curl-up task was no widening or narrowing of the infrasternal angle. I wanted to feel lovely tension in the midline. Shouldn't be able to feel the viscera. I shouldn't be able to feel the aorta. We measured, so here we see at rest the Inter-Recti distance between left and right rectus abdominis. We asked them then to do an automatic curl-up task. Here's the Inter-Recti distance on her automatic curl-up task. You can then see as she precontracts transversus, there's a drawing lateral, a tensing of the posterior rectus sheaths, and an increase in the echogenicity of both the posterior rectus sheaths and the linea alba. And then on the curl-up, we also, at the same time, or during the same session, looked at the response or the activation pattern of transversus and the internal oblique. Okay, so that's what we measured on the 17 healthy subjects. Now, the results, well, as you would expect, there was minimal distortion of the linea alba at rest. So first of all, we could see a linea alba both at the points, at the U point, which was just above the umbilicus, and at something we called the UX point, which was halfway between the umbilicus and the xiphoid. So minimal distortion meant no wrinkling, no sagging, and no doming of the linea alba. And so on the control subjects here in the graph on the bottom, the white dots represent the averages of the 17 subjects. So pretty consistent across all tasks, whether it's an automatic curl-up or a connecting curl. And there was also less than 20% change in the Inter-Recti distance during this task. Now, some of them did change. Some of them got narrower and some of them got wider, but none of them changed more than 20%. Now, remember, we've got some people in this study who have non-optimal recruitment strategies, so it's going to be really interesting to start to look at the correlation between this strategy, the abdominal wall strategy, and the Inter-Recti distance, okay? We haven't looked at that yet. So regardless of the strategy for the curl-up, there was less than a 20% change in the Inter-Recti distance. So on average, there was no increase in distortion, no change in distortion, regardless of the strategy at either the umbilicus or at a point halfway between the umbilicus and the xiphoid, which is the area of the abdominal wall where most of the DRAs, most of the diastases occur. So our hypothesis is that tension of the linea alba, and it's important to mention that the distortion index is not a measure of tension. We hypothesize that it represents tension, but it's not a direct measure of tension. So it can only be a hypothesis at this point in time that the linea alba tensions maintained at rest in healthy subjects and during a curl-up task, regardless of the strategy, at both the U and the UX points. So you should be able to maintain tension of the linea alba when you do a curl-up task. And that fits with the theories of the stability mechanisms for the trunk, the force closure mechanism, etc., etc. Okay? Well, are there differences in the behavior and the shape of the linea alba in a curl-up task in women with a diastasis? And is there something about these differences that could help us understand who we should refer for surgery and who we could treat and train? Now, first of all, if you look at the abdominal walls of the women on this slide, you'll see they look very different than the abdominal wall of the normal subject that I showed you. So lots of doming, lots of sagging, depending on the strategy, and intra-abdominal pressure will dictate sort of what you see. So we use two evidence-based tests to screen for load transfer. The first one is a one-leg standing task, and there's minimal data, but there's a little bit of data looking at the sacroiliac joint in this task. And what we found is, surprisingly initially, was that a number of different regions demonstrated non-optimal strategies. And remember, that means non-optimal alignment, biomechanics, or control. In a number of different regions, yes, in the sacroiliac joint, but also in the lumbar spine and in the lower thoracic rings. So there was ring shifts in some, there was poor rotational control in the lumbar spine in others, and unlocking or giving way of the sacroiliac joint in yet others. And in some, they had the whole shebang. They couldn't control anything. And it really appeared to depend on where the greatest separation was in the linea alba. And this wasn't directly analyzed, and that's just a clinical opinion. which I think I'm allowed to have. Now, on the active straight leg raise test, which is a test that was initially proposed by Professor Jan Mens from Amsterdam, and a positive test is when there's an effort difference to lift the leg from one side to the other, and then that effort improves or is reduced when compression is applied to the pelvis. All of them had positive tests if a positive test was defined as difficulty lifting one or both legs. But the location of the location of support was highly variable in terms of where it provided the biggest change in effort required to perform this task. So some of them did need pelvic compression or pelvic correction and alignment and correction. That made the biggest difference. But more often, most of them needed fascial support in the mid-abdominal region. So around the area of the mid-lumbar spine, which would be the umbilicus, or in the upper lumbar spine just above the umbilicus. This is where support was needed, as you can see in the bottom picture on the right. And for others, it was a thoracic ring correction that provided the best correction and best change in the task. So when we looked at the abdominal wall rating for co-activation, one of the first things that I noticed right from the get-go was that the strategy chosen for the automatic curl-up task was highly variable amongst all the women with the DRA. And it was not uncommon for some of them to be dominant with their internal oblique and others to be dominant with their external oblique. And they had all sorts of different behavior patterns with respect to what happened to the Linea Alba. And so this is a video clip of Heather, and I asked her to model for me so that you could see all of the different things that women did, because she's a Pilates instructor that could do all sorts of funky things with her abdominal wall. So let's have a look, and she can show you all the different strategies, or some of the different strategies these women had. So this is an internal oblique dominant strategy. So what she's doing is widening her ribcage as she curls, drawing her diaphragm up into her thorax. And you can see this creates a relatively negative intra-abdominal pressure that draws her Linea Alba in. On ultrasound, you can see with this strategy that there's minimal activation of transversus and lots of internal oblique. Now at rest, the Linea Alba is 3.51 centimeters. And the interesting thing to note is that the Inter-Recti distance actually narrows with this strategy. The heads of rectus, the two edges of rectus abdominis actually come closer together, and the distance narrowed to 1.98. The Inter-Recti distance narrowed. Now with this strategy, she's using an external oblique dominant strategy, and so narrowing the infrasternal angle, you can see now the intra-abdominal pressure increasing as her diaphragm bears down and the Linea Alba doming. Now also with this non-optimal strategy, what we see is the Inter-Recti distance also narrows. So at rest it's 4.31, and in a moment here you'll see the left and right rectus abdominis come into the screen and the doming there. You can imagine what that distortion index was. And so with both of these strategies, the Inter-Recti distance came together. Now this is Heather's habitual strategy in that she neither widens nor narrows. She's got a pretty optimal recruitment strategy for her deep and superficial abdominal muscles. However, in spite of that, she's not able to generate any tension through a fairly large part of her Linea Alba. So those are the three most common things that we saw. And we learned a lot from looking at the abdominal wall activation strategy and what happened in relationship to the Inter-Recti distance. And although we haven't officially analyzed it, it certainly seems that these non-optimal strategies narrow the Inter-Recti distance. And so for a while now, that finding has led me to question the goal of only trying to restore strategies that close or narrow the Linea Alba. Remember the green words I referred you to at the beginning of the lecture? That closing or narrowing the Linea Alba may not necessarily be a good thing. It depends on how you're closing or narrowing it. And certainly when Paul analyzed the data, the behavior of the Linea Alba, he was able to confirm this clinical impression. Now, this gal is not a postpartum woman. She actually had radiation as a teenager in her thorax, which led to some stiffness and her separation of the abdominal wall. Nonetheless, she has a DRA and her data was included in the study. And let's look at what happens when she does a curl up. So you can see this very small doming here of the upper part of the linea alba, and you can see that we can sink our fingers through the into the linea alba, and we can actually pull the left and right rectus abdominis apart. And while she is activating her transversus a bit, there tends to be tons of internal oblique activation happening here. And the impact on the linea alba of that strategy is for the left and right rectus abdominis to come together, and this wrinkly, you can see it over here, this wrinkly linea alba to occur. So we teach her how to recruit her deep muscle system better, find her TA. Look at the difference in the form or the shape of her abdominal wall with the pre-contraction of transversus. You can't pull the left and right rectus abdominis apart because they've already been pulled apart by this beautiful activation of the transversus. And here you see the impact on the linea alba. With the pre-contraction of transversus, she gets a lovely tension in the linea alba. Note the obliquity, that's usually suggestive of the presence of a thoracic ring shift. And although we didn't analyze that in these studies, that's certainly been our clinical impression. When you see an oblique linea alba like this, that it usually means that there's a twist in the lower thoracic rings. So here's a summary of that gal's findings. So the linea alba at rest here, and in B, this is her automatic curl-up strategy and the impact on the linea alba. You can see the inter-recti distance actually narrows from its rest position, and it creates this doming of her in her abdominal wall, versus a curl-up with a pre-contraction of transversus first. So transversus pulls the left and right rectus abdominis apart. We see lovely tension here. And there's very little difference in the inter-recti distance with this strategy compared to what it was at rest. And you can see a totally different form of her abdominal wall. And there's lovely tension generated in the midline here. So the results in terms of the behavior and morphology of the linea alba in the women with DRA was this. The distortion index increased in 69% of the 26 subjects during an automatic curl-up task, which means that in 69% of them, the linea alba went wrinkly, it domed, or it sagged. And they also started further from the shortest line, which meant that there was some distortion at rest as well. And 54% and 42% of the women with the DRA could reduce this distortion at the U and the UX points, respectively, by more than 20%. So they could reduce the distortion by more than 20% by pre-activating the transversus. Now, these numbers also mean that some women could not. And remember, we didn't actually separate those who could activate their deep muscle system from those who couldn't. So they are all mixed into this study. There's a high variability in the quality of abdominal co-activation, and that likely is reflected in these numbers. So our hypothesis is that in women with the DRA, that linea alba tension is less at rest than in the control subjects, and it decreases in some. In other words, the inter-recti distance narrows during automatic curl-up task. And in some of these women with the DRA, they can increase this tension and reduce the distortion by pre-activating the transversus. So all women were then treated with the integrated systems model. They were given 4 to 6 weeks of treatment in which we found and treated the primary driver, which was highly variable for all of them. And the treatment of their non-optimal strategies, were released using a wide variety of manual techniques and self-release exercises, dry needling, ball rolling, etc., etc. And then optimal strategies were taught doing specific recruitment training using neuroplastic principles to rewire the neural network and to create a new brain map for all of the muscles of the core, basically, for all the muscles of the abdominal canister. And then finally, they were taught to integrate these new recruitment patterns into functional tasks that were necessary for being a young mom, for lifting, squatting. We did lunges, lifts, squats, because those are the tasks that they needed to look after toddlers at home. So in conclusion then, as most research often leads to, is more questions with few answers and more questions. And we certainly gained a lot of clinical expertise by having some structure layered onto our questions and the things that we were looking at in the clinic. Not everybody with a DRA had failed load transfer of the pelvic joints, and we learned that this condition can affect control of all of the joints of the abdominal canister, including low thoracic rings and lumbar joints. And where you lost control really depended on where the force closure was lost, and that really tended to depend on where the separation was the greatest. In some, with the restoration of function, the inter-recti distance got wider when function was restored, and in others, it narrowed. And the important thing to remember that whether it got wide or it narrowed, in all of the ones who were able to restore function, it appeared that tension was able to be generated within the Linea Alba. And in all of them, they were able to dissociate the deep muscle system, and they were able to use the entire abdominal wall appropriately for functional tasks. And yet, in a few, this total core training did not restore their ability to control movement in either the thorax, lumbar spine, or pelvis when loads were increased. And when you ask the question why, the reason that is even the best strategies will not control joint motion if the fascial system is unable to generate sufficient tension. So here's Heather again, the Pilates instructor with the high diastasis. And her standing abdominal profile here. So here she lets her belly go, and you can see her visceral contents sort of fall into the pelvic bowl. And then she activates the deep muscle system through a pelvic floor cue, and you can see her lower abdomen flatten and her belly lift, and her upper abdominal protrusion actually get a little bit worse, because this is where her DRA is. She's able to control the joints of her pelvis quite nicely because her abdominal wall is intact here. And what she can't control is the low thorax. And so she has low thoracic ring shifts that tend to go to the right and to the left when she stands on either leg. So this is her area of loss of control, is the lower part of her thorax. And you've seen this before, but this is a close-up now. When she does an automatic curl-up task, she's got a lovely recruitment strategy, co-activation of the deep and superficial muscles. However, in spite of that left and right co-activation, she's not able to generate tension in the midline. And you can see that even though the inter-recti distance narrows, there is a sagging or a wrinkling of the Linea Alba in between. So this is Heather 5 weeks post-op with a relaxed abdominal wall. And there's her deep muscle system activation, which gives her a beautiful flat abdominal wall. Her SI joints were fine before surgery. They're fine again after. But what she still can't control is the lower rings of her thorax. It's better, but surgery doesn't restore strategy. You still need to retrain the recruitment strategies once the surgery has fixed the anatomy. So she's a little bit IO dominant, but not bad. So if you can see my thumbs widen there a little bit, that will require some education and some training. Lovely tension in the midline now, so I certainly can't sink my fingers into her viscera. A beautiful co-activation response, so she hasn't lost the ability, her brain hasn't lost the ability to co-activate her transversus and her internal oblique. And this is what a surgically repaired Linea Alba looks like. So they don't actually cut out the tissue, but in fact they take the ventral rectus sheaths and tack them together, stitch them together ventrally with non-absorbable sutures. Now for Heather, Dr. Demianchuk did something different, and that is he did a full thickness repair. Because transversus abdominis puts tension or applies tension to the posterior rectus sheaths, we asked him if it would be possible for him to do a full thickness repair and connect the posterior rectus sheaths as well as the ventral rectus sheaths, and he was able to do this for Heather. So in some women, certainly surgery is the necessary intervention that needs to be done before training. And Christy was one of the gals, remember before that we said that would probably do well with surgery. So what happened to the gal that started all this anyway? 2 weeks before Christy's surgery, she got pregnant, and she told me that she really felt her baby was going to fall into her pouch, and I told her, yep, you're right, so you better keep good control of those abdominal muscles, which she did. And as she got more and more pregnant, she actually started to feel better and better until she was in a car accident. And she used her healthy abdominal wall to support her growing pregnancy, and really did actually quite well. But everything came undone, of course, once her baby was born. And this next clip is Christy's pre-surgical evaluation. So she's 14 months postpartum. And you can see she has a lot of difficulty transferring load on both legs, and multiple regions in her trunk are having difficulty. Both her left and her right sacroiliac joints are unlocking or giving way. She has difficulty controlling the joints in her lumbar spine, as you'll see in a moment. So I'm palpating the interspinous spaces here, and the spinous processes, and they're wiggling all over the place, so there's no rotation control with whatever strategy she's using. Her low thoracic rings are sliding left and right, and there are ring shifts in her upper thorax as well. So her entire trunk has certainly been impacted by the stretch of her abdominal wall. Still no tension at rest, even though she loaded it really well through her pregnancies, and we wondered whether or not she would grow a Linea Alba back. She actually didn't grow a sufficient enough one. The tension wasn't enough for her to be able to regain control. Very difficult to discern the medial edges of the rectus abdominis here. The width of her the Linea Alba is actually wider than the width of my probe, so it's more than 4 centimeters. And again, when she does a curl up, absolutely no increase in echogenicity of that Linea Alba. So it was time for her to get her abdominal wall repaired. So this is Christy now 10 days after her surgery, and I asked her to come in so that I could capture this video clip for a presentation I was doing in Newfoundland. And even though she's been surgically repaired, just like with Heather, this still doesn't give her optimal strategies back. So she's still unlocking on both her left and right SI joints. Her lumbar spine is still poorly controlled, as are her lower thoracic rings. And on the inset picture, you can actually see the compression garment that they wear for 4 to 6 weeks, or 6 weeks or so anyway. And that's to keep pressure on the abdominal wall to control any seroma that may develop. I asked her to do a curl-up task for me, and she said, "You must be joking." So this is a sternocleidomastoid curl-up that you're going to see in a moment. And this is what happens in the abdominal wall when you use your sternocleidomastoid to do a curl-up. Nothing happens. And in fact, the abdominal wall is quite inhibited post-op for up to about 5 to 7 weeks. So about 7 weeks later, I saw Christy again, and this was her post-op screen, and there's an incredible difference in the profile of her abdominal wall. There's her deep system connection, which gives her a lovely flat profile. And she still has a little bit of work to do because her brain isn't automatically using that now intact system to control loads. So there still is some recruitment training and some strength and conditioning training that needs to be done. But Christy actually did really well, and over the next 4 to 6 weeks, she had actually more problems with her upper thoracic rings in her neck as a consequence of the car accident than she did from this surgery. So we're laughing here because it's been a long time since, or it's actually been never that I've ever felt her abdomen feel this normal. I can actually feel a fascial line between my left and right thumbs, and when she recruits the deep muscle system, she gets a beautiful activation of transversus, and I feel that magic carpet ride, the hollow, the abdominal hollowing. Lovely tension in the midline. And when she does a proper curl-up task, there's no widening, there's no narrowing. and she's got a lovely synergized abdominal wall, so she just needs to now get it stronger and use it properly. Now remember, at the beginning of this lecture we looked at the form closure mechanism of the sacroiliac joint and the force closure mechanism. So, and at that time she wasn't able to control movement of her sacroiliac joint with a deep system, a contraction of the deep muscle system. So here I'm testing the neutral zone motion of the right sacroiliac joint, and then I'm going to ask her to connect to the deep muscle system. And if the force closure system is intact, all movement in the neutral zone of that joint should be controlled. And it is, and it is. So she's ready to train. And Christy went on to do really very well. So we needed more clinical experience before we could ask smart research questions. That's really what happened through this whole journey. And if we go back and see how many of those questions that we answered that we had in 2006, first question was, how wide can the Linea Alba be before a surgical repair should be considered? And the answer is there's no relationship between the inter-recti distance and the distortion. And this means that the distortion can be large regardless of the length of the separation. It's not about the width. And I've seen women with separations between 2 and 3 centimeters that have required surgery, and I've seen women with separations of 2 to 3 centimeters that we've been able to train to get better. So there isn't a magic cutoff number for us. It means that we still have to use our brains and figure it out. So the hypothesis is that tension is more important than width, and the next step, of course, is to validate that hypothesis and to validate that the distortion index represents changes in tension. And we'll be doing a trial later on this year. We'll repeat the trial with a few subjects, adding elastography to see whether or not the distortion index does represent changes in tension. What's the best way to close the diastasis and restore the force closure mechanism? Well, it's still valid and true that the force closure mechanism is what we're restoring, it is what we're going after. But what we know now is that closure of the diastasis is not necessary for the restoration of function. In fact, in some, closure can really be a bad thing. It depends on the strategy the person is using that's resulting in the narrowing or the closure. There's many different reasons and mechanisms underlying a DRA. There's no such thing as a recipe or one exercise program that's going to fit all women or individuals with this condition. No protocols. You really need a multimodal program to find the primary driver and to restore optimal strategies for the trunk. Can we identify these specific objective findings? Well, we haven't analyzed any data with this, but certainly my 7 years of experience in working with many, many women now with this condition would suggest that if you're working with a patient who has poor control of the joints in their thorax, lumbar spine, or pelvis during multiple tasks, and you've trained the neuromuscular function of the deep and superficial muscles of the abdominal canister in an optimal way, and yet there's still no ability for this optimal strategy to control movement of the relevant joints, and they can't generate tension in the linea alba, then this suggests that surgery should be recommended. So our final take-home message is, again, when you have twists in multiple regions of the abdominal canister, many things can start to happen. And some of your patients may present with pelvic girdle pain, others with incontinence or urgency, some may present with pelvic organ prolapse, and some may present with a persistent diastasis rectus abdominis. And treatment suggestions: release and align the entire trunk. Look at all of these things as a whole person problem. Look to train optimal recruitment strategies before you move to strength and endurance training. And we really feel that through the lens of the integrated systems model, this is a perfect way to treat women with pain, incontinence, prolapse, or diastasis rectus abdominis. So as always, none of this work ever occurs in a vacuum. There's always a number of people to help or to thank. And first and foremost, I'd like to thank the patients who have given me permission to share their stories with you. because it's the patients that really challenge us to establish protocols for best treatment. And when we don't know what to do, they're the ones that really drive us to figure it out. And it's the individual patient that helps us promote physiotherapy and advance our scope of practice one patient at a time. So special thanks to the Associated Charter of Physiotherapists and Women's Health in the UK, and also the Icelandic Physio Association for inviting me to put this lecture together, which has ultimately led to me being able to share this material with you. And also many thanks to Professor Paul Hodges, who has been very supportive of this journey right from the beginning and continues to be very supportive and involved in the research. Thanks to Dr. Demianchuk, the plastic surgeon, top picture on the left there, who has put the abdominal walls back together in so many of my patients and has helped them restore their healthy, active lives. And to Christy and Heather, two gals in the middle, for supporting all the women who I give them their phone numbers of the people who are anxious about the surgery, and they've been fantastic advocates for both the research, the protocols, and the surgery. And finally, thanks to you for listening. I know it's been a bit of a long haul getting through this. I do appreciate your time and attention. Invite you to join us in the future for a new course that we will be offering starting next year at Diane, Lee and Associates. If you are interested in the integrated systems model approach, we'll be offering a clinical mentorship in this program. So check it out. It'll be on the website fairly soon. In terms of where it'll be happening, it'll be close to Vancouver, BC. It's actually in White Rock, South Surrey, and we hope to see you on a course sometime. Thanks again.